Hello, my name is Dr. Robert Remian. I'm a clinical psychologist and professor of clinical medical psychology and psychiatry at Columbia University. I'm also the director of a research center called the HIV Center for Clinical and Behavioral Studies, funded by the NIMH. Happy to be here with you today to talk about prioritizing mental health services in HIV prevention and care and trauma situations. This presentation is accredited by Columbia University. Here you see the names of the faculty that contributed to its content, and this was supported by an educational grant from Gilead Sciences. So our objectives for this training today is to, one, understand the implications of mental health conditions exacerbated by trauma situations among people living with and affected by HIV. Two, to select interventions to mitigate the effects of mental health conditions during trauma situations. And three, to be able to communicate with persons living with and affected by HIV using language that recognizes the emotional impact of trauma situations. At the outcome, we expect that you will be able to increase your understanding of the effects of trauma situations on mental health conditions of persons living with and affected by HIV, adoption of interventions to mitigate the effects of mental health conditions during trauma situations, and implementation in clinical practice of best practice-based communication strategies for persons living with and affected by HIV, particularly in trauma situations. So let's talk about the implications of mental health conditions in the context of HIV. And let me start by just focusing on why we focus so heavily on mental health in the HIV context, particularly in the midst of having successful prevention and treatments for HIV. Well, the reason is that there are significant gaps along the HIV care continuum, from people being tested to living with it, finding out they're living with HIV, being on treatment, adhering to treatment, and suppressing their viral load. Mental illness influences every step of both the HIV prevention and care continua. Persons living with HIV have significantly higher rates of mental health symptoms and disorders. The estimated incidence of HIV in people with serious mental illness in the U.S. is 6% compared to the overall incidence in the general population of 0.6%. So it's also relevant to people and their acquisition of HIV. And I believe that if we do not address behavioral health, we're unlikely to achieve the global 90-90-90 goals, which are now actually talked about 95-95-95 for ending the HIV epidemic, which is 95% of people knowing their status, 95% of people living with HIV being on treatment, and 95% achieving viral suppression. I also believe that the human right to health means everyone has the right to the highest attainable standards of both physical and mental health. Here are the most common mental health-related problems among persons both affected by and living with HIV. Depression is number one. And you see very wide estimates of intervals here because it depends on the study and how you look at this cross-sectionally or historically. But depression can be as high as 60% of people who are affected by HIV. Also, alcohol and other substance use disorders, be it current, which is lower than lifetime, higher prevalence of people lifetime, anxiety disorders up to 40%, post-traumatic stress disorders, lifetime between 40 and 64%. Of course, this is very relevant to trauma, which is one of the themes of this presentation today. And also the experience of HIV-related symptomatic cognitive disorders, the experience of pain, and the experience of insomnia. And you can see very high prevalence of all of these things. HIV transmission risk in people with mental health conditions often occurs as an indirect consequence of multiple individual, social, and system factors that are disproportionately common in this population. So the reason for the increased risk of HIV infection in the context of mental health also has to do with other social determinants of health, such as low socioeconomic status, unstable housing, or even nutrition, sexual and other physical violence being in their backgrounds or in their community, early sexual debut at times, the use of drugs or alcohol during sex, and also other illicit drug use. And these are barriers to engaging in HIV care among people with mental health conditions. Retention in care and adherence to care is impacted by, again, individual factors such as homelessness and substance use, more interpersonal or structural factors, such as how they're treated by clinic staff or their ability to get their prescriptions refilled or having limited clinic hours. Also, social factors, such as the experience of stigma and social support. Periods of active mental illness often accompanied by behavioral impairment, including apathy about healthcare, resulting in missed opportunities and poor adherence to antiretroviral therapy. Here you see a sort of a picture in a diagram of how these things are intersecting and related. And this is focused on the high burden of mental health in the HIV context and this intersection of HIV and mental health disorder. So there are, unfortunately, intersecting stigmas, a stigma around mental illness itself, around HIV, around being a member of a gender or sexual minority, or someone who uses substances, or has or does engage in sex work, or being a racial or ethnic minority. There's also psychosocial factors in terms of social support, the experience of loss, the experience of trauma, of course, including things like gender-based violence, and then the fear of illness or illness progression. We have socioeconomic background factors, demographic factors, also community factors, the density of communities, and this is true just across the globe, the safety or violence in neighborhoods or how cohesive a community or a neighborhood is. There are biological factors, which I'll talk about in a little bit, which includes chronic immune activation and HPA dysregulation, as well as other co-infections that are common in the HIV context. And then we have broader environmental factors, such as weather and health, natural disasters or war or conflict, migration. And of course, I'll be talking a little bit today about the COVID-19 pandemic and how that intersects as well in the HIV context. We know through a lot of research that mental illness is associated with poorer HIV/AIDS health outcomes. Many studies have shown that these mental health conditions, including alcohol and substance use, are associated with increased morbidity and mortality, non-initiating or adherence to antiretroviral therapy once initiated. They're associated with slower virological suppression, faster virological failure, and increased ongoing HIV risk behaviors. Let's talk a little bit about specifically the effects of trauma situations on the mental health conditions in the HIV context. So we're really here talking about psychiatric vulnerabilities. Persons affected by and living with HIV have a higher prevalence of substance use and mental health conditions that might present unique risks and challenges when trauma situations occur. Increased rates of depression, anxiety, substance use, and PTSD disorders have been found to be more common following natural disasters, such as the experience of earthquakes, or hurricanes, or floods, or fire. Also neighborhood and interpersonal violence, just thefts and robberies, gun violence, partner abuse, and other health threats, such as the COVID-19 pandemic. So that people with pre-existing vulnerabilities to psychiatric disorders, including the most common that I'm talking about, anxiety, depression, obsessive symptoms, substance use, suicidal behavior, impulse control disorders, are especially vulnerable to stress-related symptoms in the context of traumatic background and traumatic situations. And then it's important to remember and realize that long after the physical threat of infection has subsided, such as with HIV or the initial part of HIV or with COVID, psychological sequelae in vulnerable people and the behavioral effects of persistent distress will likely be ongoing. Talk a little bit about the COVID-19 that we've all been living through for many years, and you know, where it's not as intense as it was a couple of years ago, but it's still ongoing. And there's concerns about on future epidemics like COVID-19 and other respiratory illnesses. Health systems around the world have been impacted by COVID-19. And it directly affect the general population and, more importantly and more intensely, vulnerable populations, as I'm talking about. It also indirectly affects non-COVID-19 healthcare. So in the HIV context, vulnerable populations may be dealing with COVID-19 related risks, such as reduced immune competence and a higher prevalence of comorbidities, which may complicate and worsen other medical conditions like COVID-19 infection. Large numbers of COVID-19 patients did overwhelm the healthcare system, which unfortunately led to a compromised quality and continuity of people for chronic HIV treatment and care, as well as other chronic physical conditions, be it diabetes or hypertension or any kind of cardiovascular disease, etc. The poor baseline mental health was exacerbated by the need for social distancing, for physical distancing. These restrictions brought about increased isolation, which contributed to and can contribute to more depression, anxiety, increased alcohol, and other drug use. Physical distancing measures and the transition to telehealth, for some people, led to difficulty receiving or engaging in actual mental health treatment for mental health conditions, all behavioral treatment. While on the other hand, telehealth can provide opportunities for engaging people who may not otherwise be engaged in care because of transportation and travel issues. So I think we've seen it cut both ways. There are benefits, but there are also some downside for some populations. And more about the pandemic challenges of things like HIV pandemic, COVID-19 pandemic, concerned about other infectious agents. And like I said, there may be just around the corner, new respiratory illnesses that can lead to new pandemics. What's common among these things is their novelty, the unfamiliarity, and the mysterious nature of them, particularly when they first start. They're brought about by an invisible agent, the virus that you can't see. There are typically delays in detection, knowing that someone is living with the virus or has the virus in their body. The potential for isolation, quarantine, and then associated stigma is a backdrop to all of this. And early on in these kinds of pandemics, there's a shortages and scarcity of supplies and treatments. Unfortunately, a lot of misinformation through social media, through community, and it's important to get accurate information out there and not misinformation. There was, unfortunately, we saw anger and scapegoating and a lot of fear and uncertainty when there were the early breakouts of these things. The universal challenges include things like universal stress and loss and changes in routine and daily living, the reality of the death and loss of loved ones, and the physical isolation, again, the social isolation, increased loneliness. And this is particularly for vulnerable populations who are already dealing with mental health conditions. People experience job disruptions and loss, financial hardships, loss of milestones and celebrations, not being able to get together with family and friends during the peak times of pandemics like COVID-19, not having the usual celebrations of events, be it holidays or graduations or wedding ceremonies, etc. Disruptions, we saw disruptions in education and work activities. We're just beginning, I think, to really understand the hardships and the impact on children and their education and their socialization because of the isolation that took place. A lot of difficulty in people's relationships, and a lot of changes to neighborhoods and communities with the financial suffering and various businesses shutting down, which really did change a lot of neighborhoods and communities. We saw a disruption of usual medical care and usual monitoring of people's health conditions. I already mentioned non-maintenance of steady supply of medications. And so unfortunately, people's acute physical symptoms were not getting addressed. People were saying, well, I'll just deal with these symptoms and not go to the doctor or not go to a clinic setting because what's going on with this pandemic. and that kept people away from the healthcare system. And particularly, a lot of mental health and substance use treatment was not getting delivered to people at the peak of this pandemic. And there was reduced HIV-related social supports. A lot of community-based organizations, unfortunately, were also disrupted, or maybe went bankrupt, or went out of care, or had to close down. For people with HIV, the fear that living with HIV and its own comorbidities, the fear that it increases the risk of succumbing to COVID-19 or having a worse outcome if becoming infected with COVID. And for a lot of people, there was a lot of experience of a re-experiencing of the trauma and loss from their earlier HIV experiences when they first found out, or the multiple loss that took place in the 1980s and 1990s into the 2000s, where there was a lot of loss, and the COVID-19 re-traumatized this community in terms of that kind of multiple loss in their communities, particularly with the disparities that we've seen in neighborhoods and healthcare. A lot of stressors during quarantining itself, longer durations associated with poorer mental health, specifically post-traumatic stress symptoms and avoidance behaviors and anger, fear about one's own health or fear of infecting others, the confinement, the loss of usual routine, reduced social and physical contact with others, led to boredom, frustration, a sense of isolation from the rest of the world. Again, as you're seeing, this exacerbates people with an underlying mental health condition. And so it exacerbates and worsens it. The inadequate supplies for people, source of frustration and anger, not being able to get medications, and lots of cases where people ran out of prescriptions. There were delays in getting the medications that they needed for their chronic health conditions, including HIV. And we all know how important it is to maintain antiretroviral therapy once one is on it and not to have disruptions. And we saw a lot of insufficient and a lot of lack of clear guidelines about what actions to take, confusions about who needs to quarantine, when to wear masks, lack of clarity about levels of risk. And that led to more anxiety in our population. And then even after going through intense periods of quarantine, people were suffering with the ramifications of financial loss and socioeconomic distress, and leading to more psychological distress and anger and anxiety. Unfortunately, these intersecting stigmas, clearly we know that there's been a lot of stigma around HIV, and there was some stigma, not as dramatically around COVID-19, but it provoked social stigma and discriminatory behaviors, particularly against certain people of certain ethnic backgrounds, unfortunately, as well as anyone perceived to have been in contact with the virus. So this avoidance, withdrawing, and treating people with fear and suspicion. I think it's important that we take lessons from these kinds of pandemics and our response to them, and even to think about how we would apply them in the future. If and when quarantining is a public health necessity, when it's deemed to be so, it's important that it be as tolerable as possible, really to have clear communication to people about what is happening and why it's happening, and keeping them abreast of evolving information, and trying to avoid people paying attention to inaccurate information. When possible, explain how long it will continue. Thinking about providing people with meaningful activities or ways of continuing to engage socially and in education, etc., while in quarantine. Clear communication about these things, and being mindful of maintaining steady supplies for people, including food and water and medical supplies and prescriptions, and reinforcing the sort of positive message of why we do some of the things, or why we're advised to do things like quarantining or wearing masks. It's to keep oneself safe, but also it's about protecting those around you, particularly those most vulnerable, those who are very young or older, or people with pre-existing serious medical conditions, and that, just being health authorities being grateful to people who are taking care of themselves and and taking care of each other and taking care of their family and their neighborhood and their community. So some of the key messages are that any kind of traumatic situation, including natural disasters and other disturbing or stressful health situations, do result in increased psychopathology, increased mental health and behavioral health conditions. COVID-19 has increased levels of stress and anxiety among the general population, but particularly among people affected by and living with HIV, and it did have a direct impact on their mental well-being. The impact of COVID-19 is detrimental to the well-being, I'm talking about health and psychosocial of the HIV community and their continuous engagement in care. So what are some of the treatment interventions that we can have in place, we put in place, we can practice to mitigate the effects of these mental health conditions? And we want to look at the comorbidity of physical and mental health disorders. So it's always interesting, while the brain and body form one integrated system, unfortunately, it seems like the care for them tends to exist in silos. This may in part reflect the stigma of mental illness and limited training in primary health care for dealing with mental health conditions. Often healthcare providers, medical primary care providers, often believe that taking care of people with mental illness is not their job, or they feel inadequately trained to deal with mental health problems because it's abnormal behavior. I want to talk a little bit about, there are things that people who are not mental health specialists, general primary healthcare providers, can do in the behavioral health realm. It's important to note that behavior is strongly associated with treatment outcomes for all conditions, not just HIV. Non-adherence is the number one cause of treatment failure across chronic health conditions. Unhealthy behaviors are the number one cause of premature death. So that clinicians, even without specialized mental health training, are on the front lines of addressing these problems. Much can be done without specialized mental health training. Starts with the availability of mental health screening tools, which I want to advocate for being used in all practice settings. These are just an example. There are numbers of validated and widely used screening tools that can be put in place, that can be administered by a variety of personnel in clinics and hospital and care settings, which just might give you an indication that there's something worth following up on. When choosing a practical screening tool in primary care, it's practical when a range of providers can administer without specific training, or even can be self-administered. Think about clients or patients sitting while they're waiting for their appointment. And more, I think all of us experience forms we have to fill out, and sometimes they're even on digital platforms where people can self-administer some of these screening tools that a provider can then just glance at, look at, and can comment on where people indicated a positive on something like feelings of depression or anxiety or using a lot of alcohol, whatever you're screening for. They're good when they're short and easily scored and free and available, which most of these are. And there's good research evidence that they work in primary care settings for picking up, for leading people to further assessments and also to the care that they need when they are positive on screening for some kind of behavioral health condition. And I want to draw the distinction between mental distress and mental disorders. Everyone experiences distress, right? But that's to different degrees of severity. It can occur in response to any adversity. Often it does not meet criteria for a psychiatric diagnosis, requiring specialized mental health interventions. And distress responds well to what I call more supportive strategies. Now, when you do a screening, and then if that leads to a further evaluation, we're going to identify people who do have mental disorders. And they cause persistent, severe subjective distress. They can lead to functional impairment. They'll be recognized in the diagnostic criteria for meeting the qualifications for a disorder. And these do call for evidence-informed mental health interventions that where they need to be delivered by someone with mental health training or a mental health background. In HIV care, I think it's important we can improve attendance at appointments and adherence to treatment and care. It needs to remain a priority for all of us if we want to really end this epidemic by suppressing viral load among people living with HIV and getting people who are vulnerable to HIV onto things like pre-exposure prophylaxis and other prevention tools. What's useful in care settings are the use of patient navigators or peer supporters and peer navigators. Having integrated care where we're integrating behavioral health with physical health and not putting them in silos. And also all our collective efforts to decrease stigma around mental health conditions. And that may increase willingness to present for HIV treatment. So if we talk about mental health conditions and normalize our inquiries and concern and care about the mind and the body together, we can help destigmatize even asking questions about people's well-being and their mental health symptoms and conditions. Here you see examples of clinical interventions in primary care that actually require limited specialized training. It starts with building a strong therapeutic alliance with your patient, having good rapport, good doctor-patient relationship, treating people as human beings is a really sound starting point for addressing people's well-being and their mental health as well as their physical health. Using and practicing motivational interviewing or even just techniques to help increase adherence and reduce harmful behaviors by really tapping into people's own motivations for health and well-being. Use of the SBIRT model. SBIRT stands for screening, brief intervention, and referral to treatment. It's an evidence-based approach to identify individuals who use alcohol and other substances at risky levels. And SBIRT has been shown to be valid and reliable in identifying and improving outcomes for people who use substances. The other things that a general primary care provider can do is prescription of buprenorphine to patients with opioid addiction, or prescribing bupropion and varenicline for smoking cessation. Again, these are things that contribute to overall health and well-being that can be delivered in healthcare settings. I also think that in healthcare settings, think more broadly psychosocially, even in primary care, that we are checking with and knowing whether our patients are experiencing insecure housing or food insecurity, and knowing about their social supports and thinking, are they isolated or do they have social supports that they can turn to in their neighborhoods, in their networks, in their community, in their family. Of course, maximizing access to health insurance and other benefits, and including things like enhancing employment opportunities. So again, not that a primary care provider is going to be delivering all of these things, but knowing the nursing team, the doctor's team, knowing what's going on in this patient's life, and then being able to refer them for case management, social work, for other kinds of services. Here I'm showing you the WHO pyramid, which spells out the spectrum of care for behavioral health conditions. The reason I'm mentioning this is, you remember when I talked about mental distress to mental disorders, that the reality is that the majority of our patients and clients, the majority of people that we treat and work with, they don't need intensive services. We need to help them with increasing their self-care, but also accessing informal community care and things that are really more readily available, that not too intensive, and are less expensive. So what you see here is where the higher frequency of need is at the bottom of the pyramid, it's also the lower cost things that we can do. As you move up the pyramid, which are for fewer people, but the costs do go up. For psychiatric services, for instance, in general hospitals or community mental health services. And then for people with severe and persistent mental illness, leads to sometimes long stays in facilities and really specialist services, which are more costly. But again, I want you to keep in mind that at the bottom of the pyramid, we can all do a lot more to promote self-care and better community care for our patients. This was something that was written and published quickly during the COVID-19 pandemic by colleagues of mine at Columbia. And I thought it was useful to just to see, what thinking about this in general for all of us in the general population. It was important that they recognized to begin with those who are at increased risk for adverse mental health outcomes. So in other words, as I talked earlier about people with pre-existing mental disorders, more vulnerable to stress during trauma and during the COVID-19 pandemic, which was quite traumatic in 2020 and in 2021. Focusing on people who reside in high COVID neighborhoods and prevalence areas, or people living with someone with the disease, having close friends who have died, people who are socially isolated, but also for healthcare professionals, the importance of mitigating adverse mental health effects, ensuring protective equipment, providing good access to ongoing testing, education around COVID-19, and providing emotional, physical support and more flexible work schedules for the workforce, and having a commitment to support workers on the front line. We learned that, and it's very important that we pay attention to that. Increased primary care mental health surveillance through routine screening for depression, anxiety, substance use. And this I think it was brought to the world's attention on mental health because of what we all lived through with this pandemic. And so the importance of scaling up mental health treatment and looking to nurses and social workers to provide some of the frontline evidence-based psychotherapy in these very traumatic and challenging scenarios. We have a very wide array of evidence-based mental health treatments available for the treatment population. And since I'm focused on HIV in this whole talk, all of these that are available to the general population are equally as useful in the HIV context. So that I'm including pharmacological, psychopharmacological interventions, but also a wide array of psychotherapies, be them from psychodynamic to cognitive behavioral, motivation enhancing therapy, interpersonal therapy, stress reduction and mindfulness interventions, and harm reduction and abstinence treatments. All of these are evidence-based and appropriate for our patients living with or not living with HIV. And the reality is that a lot of these have become manualized, tailored to different cultures across languages, and thus there's better capability of scaling them up, including with the use of actually technology to help deliver these interventions. Now, I want to get back to and focus on the HIV context in terms of our moments of opportunities for mental health screening and intervention. And this is our familiar cascade, right? So when people are accessing STI testing and treatment, and when someone has an STI, of course, they are and should be tested for HIV if they're not already living with HIV and know their status. They may be eligible for PrEP. People who are having STIs are very likely to be eligible for pre-exposure prophylaxis to prevent HIV, which is very effective. So that's a time to also screen for one's mental health. When someone does test positive for HIV upon diagnosis, again, screening for their mental health and well-being. When they first come into a care setting and connected to care and treatment, and all throughout care and treatment. Think about HIV ongoing treatment and care. We want routine viral loads on people. We may want maybe less regular, but we want CD4 counts and functioning of the immune system. But just as we always want to know what their viral status is, we want everyone to be virally suppressed, I would promote and suggest that we also want to know how they're doing mental health-wise, how they're doing with their care, not just when they first enter the care system, but throughout care. Let's check in with them because people's lives change and depression may come about, which wasn't there before, or anxiety or experiences of trauma and distress, or all of a sudden they increase their alcohol or substance use. So I'm promoting screening in an ongoing way in HIV primary care settings. And of course, when initiating and remaining on ART, so that everyone living with HIV can be undetectable, That's good for their own health. And of course, we all know U equals U, undetectable equals untransmittable. That means that if someone is virally suppressed, they cannot pass the virus on to their sexual partners. Let's talk about effective communication strategies for people living with HIV, with mental health conditions, particularly that are related to trauma situations. So kind of like the do's of safely talking to people who are in distress or experiencing trauma. First of all, acknowledge the stress and the trauma. Just acknowledge that it's there and it's real for this person who's experiencing it. Think about resilience. Ask people how they cope with difficult situations. How have they been resilient in the past? If they're going through trauma now, or you're hearing about past traumas that are being repeated, what has helped them get through? What resiliences do they have? So you're affirming their ability to cope. In other words, their resilience. In the new current situation, ask people what usually helps them feel better. And maybe that's something they can try and focus their energy on. So in doing this, we're affirming positive coping strategies and discouraging negative coping strategies, such as abusing substances or over drinking or overeating. It's important that we do not pressure people to tell their story or necessarily talk about their trauma unless they are doing that and they want to talk about it. In other words, we don't want to push people or force them to relive a trauma if they're not wanting to talk about it in that moment in time when you're interacting with them. Of course, we should always be non-judgmental about what situation a person ended up in or found themselves in, to be mindful of our language, that we're not sort of, quote unquote, blaming the victim or making them feel bad or judge because they were in a certain kind of situation, such as a domestic violence situation or something like that. It's important to not think and act as if you must solve all the person's problems. Just hearing their story that they're willing to tell, acknowledging the trauma they're experiencing them, and sort of being a shoulder or a helping hand is important. And you may not have all the answers, and you may need to bring in other team members to really help address the situation. And not taking away the person's strength and sense of being able to care for themselves. So again, tapping into their resilience. The common signs of distress in the midst of or after traumatic situations include feelings of numbness, disbelief, anxiety, fear. People may experience changes in their appetite, their energy, their activity levels. This can be prolonged after a traumatic experience. So to be mindful of these kinds of things, they may have difficulty concentrating, difficulty sleeping, of course, having things like nightmares or upsetting thoughts, intrusive thoughts and images, physical reactions to stress and trauma, body pain, headaches, GI symptoms. They may have more anger or be short-tempered. As I've mentioned, they might be increasing their alcohol or tobacco or other drug use, or you may see a worsening of chronic health problems. These are all things to be on the lookout for and to inquire about when it comes to people experiencing any kind of traumatic situation, be it repetitive or new or single incidents or multiple incidents. And of course, I always like to give messages to you, to providers, to all of us. Everyone needs to seek mental health care when needed. Let's destigmatize the need for mental health care. If distress impacts activities of your daily life for several days or weeks, or your symptoms are becoming more severe yourself or for people you know, your family and friends, important that you reach out or help people reach out for care. There are a lot of local and national resources to respond to traumatic situations that may be experienced, particularly in the community. And so there are national helplines. And of course, in your care settings, hopefully there's people that can be contacted or referred to, whether it's for yourself or people that you know. When we're facing difficult times, it's important to take stock, right? Look at our own emotions. What emotions have you been feeling? Are these feeling different for you? Which feelings are predominant? What about your physical feelings? Are you feeling more tension, anxiety, stress, frustration, changes in your own appetite, sleep, or energy level? Be mindful of your own health, your own mental health, your own well-being? Is there a change in your activity level? Find yourself withdrawing from others, or unable to rest, or feeling agitated, taking on too much. I think a lot of healthcare providers are vulnerable to taking on too much, not giving themselves breaks, and maybe not engaging in activities that they know are important to their care, like exercise and other self-health care. And think about how their social life maybe has changed. Are they spending less time recreational, seeing with friends, getting together with friends? There are a lot of studies coming out that I'm reading about that are the importance of just social connection really contributing to better, not only mental health, but better physical health when people are connected to others in their world. Helping your patients cope during traumatic situations, and during periods of trauma. Checking in on patients virtually can be very comforting and meaningful. Just even check-ins. I hear so many patients being so grateful when someone from the healthcare team actually just reaches out and checks in with them. I think we have to accept that some level of anxiety during traumatic periods is normal, that people should seek social support for wherever they can get it, and whether in person or virtually, helping people create and maintain regular routines, continuing when possible to engage in pleasurable activities. What are things that soothe people, be it yourself, your family, your patients? Listening to music, exercising, meditating. For some people, it's spiritual practices. Whatever it is, remind people these are things that are good for one's mental health and to one's physical health. Avoiding activities that do cause distress. For some people, I hear it's listening to the news or watching too much cable news is stressful to them. Well, maybe they don't have to watch so much. They can do something else. It's important that everyone get enough sleep. Try and have regular routines for sleeping and waking up. And of course, it goes without saying, maintaining good nutrition and avoiding excessive use of alcohol, drugs, tobacco, caffeinated beverages. I think we can all play a role in teaching people about trauma and its effects and all these kinds of symptoms people may be experiencing. The importance of using relaxation to control one's own behaviors and actions. Making recommendations for people to be mindful of their sleep, their diet, their exercise, and helping people identify and control unnecessary feelings of guilt or shame, or feelings about what they're going through or what's happening in the world around them. Focusing on changing how people react to their fears and other feelings. So in other words, we're modeling and we're helping reframe for our patients. I think this is something that our Columbia group came up with to use for people dealing during the COVID-19 pandemic, but it's applicable in other settings, right? Is always to be I think this is true in life. Be mindful of thinking about what do we have control over, what do we not have control over. We don't have control over how other people behave or what's happening out there in the world around us. So let's not beat our heads against the wall trying to change something that is beyond our control, but to help people focus on things that is within their control, right? Of their own attitude about things, or finding pleasurable things to do, paying attention to kindness and grace. And you can see a lot of these words where this was all framed around dealing with the COVID pandemic, but think about how this applies in other scenarios as well. Similarly here, when I talk about tapping into resilience and thinking about your own resilience, but also resilience of your patients, as well as your family and your friends and your own network, to think about the importance of all of these things, engaging in self-care, being connected to and living your values, being connected to others, having time for reflection, tapping into hope in the midst of very distressing times. What do we have to be hopeful for? Where do we find hope? Where do we find optimism? Tap into your own, but help other people tap into it. Cultivating gratitude is very important. To remember to express gratitude to yourself, to others, to your coworkers, that can be very, very important. Practicing mindfulness, and this can be done in a variety of ways, but even just taking a few minutes out of your day or in the middle of your busy workday to really pause and do a little bit of mindfulness exercising. Being flexible and being forgiving. We can't all be perfect, and those of us who worked very hard, try not to always be you can't always be perfect, right? So be flexible in forgiveness for faults and errors that you may make, or your coworkers may make, or people in your personal life. That if we all practice more forgiveness and flexibility, I think that goes a long way to improving mental health and well-being, and again, believe it or not, everyone's physical health. So a reminder to you providers, it's not selfish to take breaks. The needs of your patients are not more important than your own needs. It's very true that working nonstop can put you at higher risk for stress and exhaustion. You may need to give yourself more time to step back and recover from incidents or series of events, from long shifts, extended coverage in your workplace. And there are times where your work may feel more emotionally draining than usual because in the context of something like COVID-19 or just working in various settings, you may feel yourself vulnerable to infection in the healthcare setting or from your patients. So be mindful of work that can be very intensive, very demanding, and very emotional draining. And in your lives, manage stress, be it through meditation and prayer, deep and slow breathing, relaxation exercise. It's for some people, yoga and mindfulness, stretching, listening to music, avoiding excessive alcohol intake, hydration, eating healthy, exercising. I know a lot of this has been repetitive, but these are important things for all of us to keep in mind. Getting good rest and sleep. Reaching out to others, family members, friends, colleagues, coworkers. During periods of stress and trauma, it's not a good time to make big decisions or life-changing decisions. Delegate things, ask for assistance when you can, and spend time outdoors, spend time in nature. I mean, it sounds maybe simplistic or silly, but these things are important for everyone's well-being and for one's physical health. So in closing, I'd like to just summarize some of the messages I hope you've gotten. I hope you can carry forward in your work and in your lives, and particularly in our work in HIV context for people at risk and living with HIV. Mental health problems are elevated among people at risk for HIV and persons living with HIV, and traumatic situations contribute and can exacerbate underlying mental health conditions. Mental health problems contribute to HIV acquisition and to poorer outcomes along the HIV treatment continuum. We have all of the necessary screening tools. We have evidence-based treatments. We need to prioritize mental health treatment with appropriate resources to address the gaps. And again, I'm advocating for the integration of behavioral health care into primary health care. The importance of integrating our mental health assessments and treatment in all care settings, and in the context of HIV and our goals to end the HIV epidemic, this is where it's important to really integrate these things. It's important to promote for patients who are eligible for and can benefit from the use of PrEP. And let's scale that up. And also the Undetectable Equals Untransmittable campaign to provide opportunities for improving well-being, quality of life among people living at risk for HIV and people living with HIV. We've made tremendous advances in the HIV field with all of our tools of PrEP and HIV treatments. So people can live healthy lives with HIV, and they also can prevent themselves from getting HIV, even when there's sexual risk behavior going on, if they're using PrEP and if people are undetectable who are living with HIV, with their viral load. We do need advocacy for human right to a highest attainable standard of mental health, and let's try and prioritize that, and let's be advocates for mental health and well-being, and not keep it siloed and separate from physical health. Um, Mental health treatment is particularly suited to use of virtual methods in providing services. I think telemedicine technology, it's existed for several decades, but it's taking the impetus of COVID-19 for it to come more widely used and more normal for people. Let's continue to advance our use of technology to bring mental health to people, to all people. Developing support groups and peer counseling services, helplines, expanding and enhancing accessibility through the use of telemedicine. It may help some of the addressing and what we're recognizing emerging health needs for all ages. We're seeing it among young people. We're seeing it from middle-aged people and older people. And again, formalizing linkages between primary care and specialty mental health. And the careful planning, integration of basic mental health services into outpatient primary care, including HIV care, of course. This is critical to minimizing the adverse mental effects of other health situations, other health pandemics that can happen around us. Here you see a list of resources that are available online, and this is good to have for you to know yourself, to share in your work settings, in your clinics. And here you see a listing of the references of the materials I presented to you, some of the background for the research that I presented in this whole presentation. And these are available to you if you want to read more specifically about these. And in closing, I want to say thank you for taking this course. Thank you for being here. I hope these were some helpful tools and techniques for you to use in your practice. And let's all be advocates for the reality that mental health does matter. I think you're familiar with the phrase, no health without mental health. And so let's all be mindful of this integration of mental health and physical health. Thank you for being here. Thank you for paying attention, and thank you for your time. Take care and do well in your work. Thank you.